Thanks very much. I'd like to thank the SSG organizers for inviting me here. And on behalf of all stroke neurologists, I'm not a surgeon, I'd like to congratulate the Enrich investigators for a terrific job with this trial. I kind of feel like this is the thrombectomy moment for hemorrhage. We worked, this kind of reminds me of the early last decade where thrombectomy went through a rendition of failure before success. And I feel like this is that key major for success. So terrific. And I can't believe how many enthusiastic neurosurgeons in one room to operate on hemorrhages. So on behalf of all stroke neurologists, we need you. There is an army of probably 20,000 stroke neurologists around the world who will be contacting you for surgery. So please engage us. So I'm going to talk about patient management, really the medical side of things, and I'll try to make this quite interesting for you. I'm a trialist and an imager and like to try to better understand this disease. Hemorrhage, I think the analogy of Death Valley Run is a very good one because it also applies to our struggles with medical management. And so the things there in bold are some of the activities that I'm involved with currently to try to improve on hemorrhage treatment. I'm going to start with this slide, which is essentially painting a picture here. Intracerebral hemorrhage is ischemic stroke growth on steroids in that most of the expansion actually happens very likely in the first 2 hours. In fact, I suspect in half of the bleeding strokes that expansion is said and done within the first hour or so. And so we need to compress our medical management to the first 2 hours. And I'll give you some nice examples of data that's emerging because we are getting some very interesting and somewhat positive data in medical management of hemorrhage. I'll start with this slide, which is important. It's a logarithmic curve slide, essentially, which outlines that about 40% of bleeds likely stop bleeding right away, first 15 or 20 minutes when a mature clot forms around a rent. But then about half of bleeds will continue to expand, especially in the first hour. And that gradually reduces. And so by about 3 hours, only about 10 or 15% of hemorrhages are still expanding. Okay, so the expansion of an hematoma is really a phenomenon of the first 2 to 3 hours. And so all of our treatments have to push much more early. This is data from FastMag, which was a pre-hospital randomized trial in stroke, which showed very nicely that in hemorrhage patients, 1/3 of ICH patients deteriorate in their LOC between the pre-hospital evaluation by the paramedic and the second assessment emerge. Very early in the process. 1 in 3 hematomas. In ischemic stroke, it's much less commonly seen. So there's a lot of expansion that's happening in those critical 2 hours. This is the chain of survival. I'll talk about some elements of this very quickly for you, what I think is relevant to neurosurgery. But we need to compress all of this. It's very clear. Stroke neurologists are keen to do that. So we'll see what happens. First off, it's becoming abundantly clear we need to start detecting ICH in the field. And this is, of course, where the mobile stroke units have a significant advantage, but we have far too few of them globally to deal with the problem. Plasma GFAP, very simple blood test, appears to be very promising for separating out an intracerebral hemorrhage from an ischemic stroke in the ambulance. Why is that important? Well, we have data now that have emerged that where we transport the patient matters in terms of hemorrhage, and blood pressure lowering may also matter in hemorrhage. RaceCat was a trial done in stroke where patients were randomized at the scene, paramedic by the scene, to nearest stroke center versus comprehensive stroke center for EVT. It was kind of designed around endovascular treatment of ischemic stroke. But they enrolled intracerebral hemorrhage patients. And what they found actually was intracerebral hemorrhages were harmed by longer transports. So they actually did more poorly statistically. The reason for this is we actually shake these people up as we transport them by ambulance. There was a substantial increase in vomiting, 13% versus 2% for the long transports. This is randomized data. There was more neurological worsening, there was more hematoma growth, and there was double the pneumonia rates. So we have to be conscious of this. There's almost a motion sickness effect of a long transport. So we do need to stabilize these patients first. before we transport them to other facilities. There's also now data from the trial called Interact-4, recently presented and published in the New England Journal. This was done in China, where they randomized patients in the ambulance to blood pressure lowering, ischemic strokes and hemorrhages, to do 2 doses of a drug called urapidil. And they showed about a 17 millimeter mercury drop in the ambulance in the active arm versus the control arm. So they were able to achieve a very rapid blood pressure drop, 17 millimeters of mercury, at an hour from onset. So by getting them at the ambulance level, you were getting them around an hour. And this translated to improved clinical outcomes in this group. They actually harmed the ischemic strokes, but they benefited the hemorrhages. So we'll need even more now. We need to be able to detect these hemorrhages in the ambulance. And so the hemorrhagic strokes actually statistically did better by aggressive blood pressure lowering in the first hour. So blood pressure lowering very early appears to be crucial. We'll need to confirm this with future trials. The hematomas were smaller if we did that in the ambulance, and they grew less. So what that all means, of course, is we need to push our door to imaging. We need to scan patients very quickly in stroke, and you'll see stroke neurologists try to do that a lot more now, to try to get patients under 2 hours so we can initiate blood pressure lowering aggressively under 2 hours. And we have data from ATTACH-2, and in the population randomized under 2 hours, there was a benefit favoring blood pressure lowering. There's also now data that if we can push aggressively treat blood pressure and get it down within an hour, in a cluster randomized trial, we saw benefit for patients with hemorrhage. So we're starting to accrue some evidence of benefit in ischemic stroke. CT angiography should be performed in all patients. I'm actually quite surprised. I don't know how many of you have your centers doing routine CTA in all your hemorrhages, but there are a majority of centers around the world who are not doing vascular imaging acutely. Very surprising to me, because it'll detect secondary causes in about 10 to 15% of patients. You want to know if it's an AVM or AV fistula you're dealing with before you operate. And it also, of course, picks up the spot sign. It was great to hear some positive interest in spot sign in the neurosurgery community. We've struggled with this imaging finding. I've worked hard and long on this for a while now. It is the most strongest predictor of any predictor of hematoma expansion. It also is the strongest predictor of severe expansion. So patients who have more than 12 mils of growth or 67% growth, the spot sign has a 5-fold increased risk. So it's very good at picking up patients who are likely to expand their hematoma substantially. And given some of the discussion we had here about do I consult on that really small hemorrhage with a spot sign or not, this can be quite relevant. We also know the spot sign increases the risk of intraoperative bleeding and postoperative bleeding. So I think it has value for neurosurgery. This is a review we're working on right now. There's more to the spot than just the spot. We do 3-phase CTA in Calgary. A lot of centers do this now for collateral assessment in thrombectomy decision-making. But we actually like this particularly in ICH because what it shows is a change in the spot sign over about 45 seconds. You basically move the gantry back over the brain twice more and image the brain 3 times. And you essentially see the spot sign expanding. And it's that expansion of the spot or even diffusion of the spot that actually suggests a much higher risk of hematoma expansion. So very simple. We published this in AJNR recently. But so spots are not all created equally. You can actually get some idea of leakage rate of a spot sign by imaging the brain 3 times over about 45 seconds. A really cool thing that we recently identified is something we call the black and white sign, where you look at the spot sign, you can identify the spot sign, and it corresponds to an area of what we call hypodensity in the clot. What that hypodensity is felt to be is recent bleeding. That's uncoagulated blood in the hematoma. So when you see a spot sign in a hypodensity, this actually strongly predicts massive bleeding in some patients. About 7% of hemorrhage patients will have the so-called black and white sign. What about anticoagulation reversal? Anticoagulants, of course, are a risk factor for hematoma expansion. We have some agents that we can use for reversing. We now have a randomized clinical trial comparing andexanet to PCC as a reversal agent in factor Xa inhibitor bleeding. And andexanet did perform better in reducing hematoma expansion, including severe expansion. but it did increase thrombotic events. So there is an upside and a downside to using this antidote therapy. One very important thing I want to tell all you neurosurgeons is andexanet, I've worked closely with this drug for a while now, loses effect within 5 hours of bolus, completely. So if you're transferring a patient, an anticoagulant bleed from afar, in sort of northern Indiana or somewhere, and several hours have transpired, there is a possibility that you have an anticoagulant effect in that patient again at about 5 hours. The effect, it's a decoy, it only lasts as long as the bolus and the 2-hour infusion, and then it quickly loses effect. So be careful in someone who's recently received 10A inhibitor that's had an andexanet many hours before. There could be an issue there for you in the operating room. Hemostatic treatments have been disappointing so far. The fastest trial is a trial that's being led by Joe Broderick. I'm involved in this fairly closely. This is factor 7A, under 2 hours from onset in hemorrhage. We just passed the 500 enrolled patient mark. So this trial will complete enrollment within about a year. So we'll have our last chance to show whether hemostatic treatment has an impact medically on these patients. How about consulting you and transporting patients to you? The guidelines here are not very updated in this department. We need to update all of our guidelines globally on this. The stroke neurologists need advice on when to call you. They're all basically outdated. They're all based on stitch criteria, essentially. Is it 20 cc's? Is it 30 cc's? Is it 10 cc's with a spot sign? And when is it too big to call you? I don't want to hassle you at 1 a.m. For 120 cc hemorrhage unless I have to. And so I'd open it up to you maybe as a question at the end. What is our threshold here? I can go back and pass that on to all my stroke neurology colleagues internationally. What is the threshold to involve you? We don't want to bother you unnecessarily. What about non-neurosurgery considerations? Well, is there a specific CT protocol we need to be using for neuronavigation? How often do you use neuronavigation now? I got a sense that there's maybe a bit of a shift away from that a bit. Is there a role for pre-op hemostatic treatment? Should we be doing a randomized clinical trial of factor 7A before we operate? Is that something of interest to you? Would you participate in a trial? Or are you comfortable with the hemostasis surgically? And then post-op care. One thing I will tell you, please be careful with lowering blood pressure. Too much for too long is bad. We're starting to realize that now. There's probably a perfect blood pressure reduction of between 30 and 45 millimeters of mercury systolic, where you get the best outcomes. We know that if we take a patient above 220 and we lower it to 120, we substantially hurt the kidneys and we substantially cause neurologic deterioration. The other thing that's been shown is we see a decreased diffusion. We see much more what we call internal watershed infarcts if we lower blood pressure 60 or more millimeters of mercury. And this is an MRI showing basically a string of pearls of internal watershed infarcts. This is caused by our intervention. This is iatrogenic from blood pressure lowering. I've seen man-in-the-barrel syndrome from patients who had their blood pressure lowered too aggressively for too long, from a very high level to a very low level, and we actually infarct out the internal watershed zone. So do be careful there. This makes sense because patients with severe hypertension have their autoregulation curve shifted to the right. And so you take a patient from one end of the curve down to the other end of the curve by lowering very aggressively. So in summary, we need cheap, scalable technology for pre-hospital ICH detection. ICH should be first stabilized at the nearest stroke center and then transferred to you as a surgeon. Given the risk to long transport times in terms of bleeding and complications such as pneumonia, blood pressure lowering has a large clinical effect in the first hour and probably the first 2. Door to CT time should be minimized. CTA should be mandatory for a detection of secondary causes and spot sign. Andexanet is superior to PCC, but has some thrombotic events. Be careful, andexanet wears off within 5 hours. Our guidelines are outdated. We need advice from you on what volume range we should be consulting you, and can we help in some of these other areas to optimize outcomes. So I'll stop there and open up for any questions.
Thank you, Dr. Demchuk. Your talk was everything and more that we envisioned when we planned the agenda. So thank you very much. So many pearls that we're not used to hearing. So the first question would be, as you posed, what is our threshold as surgeons for ICH evacuation on the low end and the high end? Anybody want to venture your opinion on that? Mark?
Thanks, Andrew. That's a great talk. I think, and this is what we do in Cleveland, but I think there's a big need for multidisciplinary care here. I think the way we do it is, we usually are called from another hospital, patients auto launched in on a helicopter. At the time when the patient gets there, we usually consult the 3 services. So it's neuro ICU, neurocritical care, stroke neurology, and neurosurgery. They all meet together. And I think if it happens at the time of admission, nobody feels like they're getting dumped on. The neurologists are like, oh, it's non-surgical, give it to neurology, whatever. And I think it's really important. I think we all have things to add to this, just like, half the stuff you presented, I didn't even heard of. So it was awesome to hear that. So I think that multidisciplinary aspect is where it's at, and, have everybody input. As far as surgical threshold, I think that's what we're figuring out, and so I think it's really helpful to have that team approach here. Is the patient too sick to go to the operating room? The neurologist say, I reverse that. That's perfect. I think you're going to have good hemostasis. We're saying, oh yeah, that's a bad spot sign. So I think that's where it's at. And it's hard to do, but I think once you get it going and you have the protocols in place, I think that's where you should be.
One question that we receive oftentimes is that andexanet is very costly, so some institutions aren't able to purchase it, and they are looking for ideas on how they could convince administration to purchase the drug for them. What would you say to that, or what evidence would you use in order to assist them in getting the drug?
Yeah, I'm a Canadian in a socialized health system, so you can imagine that problem is just made worse 5-fold to what you just say. So no, it's about patient selection, right? I mean, as we have learned in everything stroke, it's a very heterogeneous disease. We want to select good patients for andexanet. So this is going to be higher risk patients for HE. And so we've done some early work on this. In fact, I'm the imaging core lab for Anexa I, so I'm going to be rereading all the scans, looking for imaging predictors like spot sign and other things. But there are some criteria. For example, we've identified that if there's something called pre-scan hematoma growth rate. So it's the size of the hemorrhage by the onset to scanning time. And what we found actually is if you have a very high pre-scan volume over time, you're very likely to expand, and you're more likely to show a benefit of andexanet over PCC. So it's going to be these early patients with sizable hemorrhages, 20 cc's, 30 cc's, in the first couple hours where you're going to see the most benefit. I would argue to the administrator that I will likely use this medication somewhat sparingly, but I need it on my shelf for these high-risk patients.
Yeah, well put. Zach?
Dr. Demchuk, thank you. Not every neurologist is as enthusiastic as you are about operating on these patients. And so I'm curious what advice you would give to us as surgeons in terms of, despite presenting enriched data and some of the other publications, how do we tell this story convincingly to neurologists that are very resistant to the idea of operating on ICH?
Yeah, I mean, start with the lobar hemorrhage. I mean, if you're really in a resistant situation, the lobar hemorrhages, you've got evidence-based data. You've got level 1A. Could we use a second trial? Some neurologists might argue for a second trial. I don't know where this is going to go. It kind of reminds me of the TPA days a little bit too. Do we need more data here to really convince neurologists? Start with the lobars. Stick to the criteria of enrich. If you've got some really resistant skeptics in your group that don't want to refer to you, and then work from there. But we all need to gain more experience with subcortical hemorrhages as well, and I certainly want to encourage that development. You're the best surgeons in the world to be doing these trials. The other thing to think about is don't be afraid to do more trials. It's those of you that are experienced that will actually demonstrate the benefit. This is exactly what happened in thrombectomy. The best endovascular people for thrombectomy got involved in these trials, and we were able to demonstrate that. So it may take more trials, but start lobar. Yes.
Dr. Demchuk, thank you very much. And we caught up again this morning, but it brings you back to ESCAPE and all the other trials coming out at a similar time. I'm just curious of your perspective of lobar and the anterobasal ganglia and from a stroke neurologist and maybe some of your colleagues. Where do you think that stands? And do you think that that's something that we should be operating on? Because I think from most of our experiences, and I know Mark's going to talk a little bit more about this in the next talk, many of those patients, do dramatically better. And we often are confronted when we're speaking about this, well, it's not positive for that. Like, well, but there were signals and it was a patient population in general and combined they were. So what's your perspective on that?
Well, I mean, you're the early adopters and the innovators here. So I would encourage that we continue to perform these procedures and continue to try to reduce our hematoma volumes. I mean, it's very interesting to see this new target of 8 mils or 2 to 8 mils. That makes such logical sense to me. And no, you don't need an ICP monitor if you've got the hematoma volume below 8 mils. I think it'd be very unlikely that that critical care needs to do that. So I want to encourage surgery here. Obviously, the data is with Lobar, and most of the purest stroke neurologists will certainly get behind that immediately. But we have to keep innovating on the subcortical side of this and keep pursuing this. I have little doubt that ultimately we'll get there if we can get the hematoma size, residual hematoma volume size down to a minimum. I think it's likely to be fruitful, but obviously we could use more clinical trials in that domain.
Dr. McDermott?
Any comments on lobar hemorrhages and the correlation with amyloid angiopathy?
Yeah, as far as I know, and the enriched investigators can speak to this, I don't know if you have looked at that, have MRIs in a subset of your enriched patients, because certainly the MRI is very good at detecting amyloid angiopathy with the cortical microbleeds. So that could be analyzed within enrich. I'm not aware of any differences in terms of benefit or outcome from enrich in that regard, but it's a terrific question and probably could be looked at in the trial.
Training, I was always told, don't operate on an amyloid hemorrhage. It'll be back tomorrow.
Yeah, I don't think that's the case. Again, I would love to see that data. There's almost every hemorrhage nowadays gets an MRI at 24 hours or 48 hours. So you should be able to look at this in enrich. I'd be surprised if the outcomes were significantly different in that group. So I'm not too fussed with the amyloid piece.
Yeah, great question. So by a show of hands, what is the threshold for the neurosurgeons here? How about 100? Is that your threshold in volume? Raise your hands. 150? Well, other factors notwithstanding, I know
Who's had a good outcome over 200 cc's? I would really curious. I know of one where patient did pretty well at 200 cc's, which is crazy, but.
Would anybody here take out other factors notwithstanding? Would you take out 200? Nobody? 150? 150 going twice? 100? 75?
Yeah, I mean, I think we've all have different experiences. I think the time is also a factor. And was that that 100, 150, was that due to an expansion, or was that how they presented with? I think oftentimes if there's an immediate deterioration and a repeat CT scan went from 30, 40 to 150, I think that's justifiable because it's just happened in front of your eyes. I think they present with the 200 cc's from the ambulance to your CT scanner with the bilateral blown people. That's probably not justified in my mind, but I mean, that's just the way I see it.
Okay, anybody else? If not, thank you so much. Fantastic talk.